Zamzam, are you there?
Yes.
Okay, so please, over to you then.
Okay. Good morning, everyone. I'm really sorry. I don't know what happened, but the system didn't allow me to join. I have to download again a new Internet Explorer. Anyway, this is the panel on the interdisciplinary field of health studies and health economics, especially focusing on the experiences in Africa. And we will start the presentation. There are 4 papers that were submitted to this panel, and 3 out of the 4 have confirmed for the presentation today. And for the 4th one, we are still awaiting. I am not sure whether the 4th presenter has confirmed. Ton, is there any update from the 4th presenter?
No, as I wrote to you, I have sent him another urgent mail to respond, but no response.
All right. So it will be 3 presentations then, and the rule of the game will be every presenter will have 20 to 25 minutes for presentation, and maybe we keep the discussion till the last presentation. But in the meantime, if there is a pressing question from anyone from the participants, please go ahead and interrupt the presenter. The first presentation is by Arjun Bedi. And to introduce Arjun Bedi, he's a professor of Development Economics at the International Institute of Social Studies. And the paper that he will present today is a paper that explores the Health Development Army and the Health Extension Program in Ethiopia. And this is a paper that has been done using a synthetic control approach that compares the achievements in Ethiopia to the other selected countries in Sub-Saharan Africa. Arjun, the floor is yours. You can start.
Okay, thanks, Zamzam. So this is a paper, I'll share my screen in a second. This is a paper written in collaboration with researchers at Addis Ababa University, and I see one of them is there, Anago Mebrati is there, so that's great. There are other authors. And it's a fairly straightforward paper, and sort of it fits in very nicely with the theme of this conference, Africa Knows, because it's sort of, although I'm presenting it because I'm here, it could have been presented by somebody else, by Anago or by GetNet. The idea of this paper is to explore the effect of certain healthcare interventions which were launched by the government of Ethiopia over the period of between 2000 and 2013, and to see the effect of these interventions on maternal mortality. So these are homegrown interventions fitting in with the ethos and the character of the nation. I think so, at least, and I can be corrected. I see a couple of Ethiopians' names. I see Meseret is there. I see Anago is there, and Zemzem, of course. So I'll get started. I'll share my screen now and get started in terms of presenting what I have. Yes. Okay, so this is a paper written with a bunch of co-authors, and in combination, we are from either Erasmus University Rotterdam or from Addis Ababa University. And what we do in this paper is take a look at, there are 2 large-scale national programs implemented by the government of Ethiopia, and these were called the Ethiopian Health Extension Program and the Health Development Army. And our focus was on looking at the effects of these programs on reducing maternal mortality in the country. And what we use is what's called a synthetic control approach, mainly because, and I'll explain what that means without getting into too many details, that since this is an intervention that affects the entire nation, we need to have an approach where we can compare Ethiopia with some other countries. So it's not just a treatment control in the sense of, well, one area gets the intervention, the other doesn't. It's a macro level intervention. And so that is why the way we have to, or the way we chose to analyze this was by comparing the outcomes in Ethiopia with other countries, or a combination of other countries. And I'll explain what that means. I think it's a very useful technique, relatively recently developed, and which can be applied in a variety of settings where the intervention cuts across the entire country. So the broader picture, rather than the interventions, is to do with sort of Ethiopia's strategies for a healthier future. Of course, all of that now, given the problems in Ethiopia at the moment, is sort of well under scrutiny as to, other aspects have taken over. But in any case, at the time we did the paper, things were a lot more, less violent in any case, and so on. So Ethiopia has invested heavily in the healthcare sector in the last 20 years. And so what this paper looks at is at the country level. So we have a whole research program on evaluating interventions in Ethiopia. And this specific paper is to do with what's happening at the level of the country. So it's not so much at the level of communities and individuals. Of course, they play a role, obviously, but the evaluation is at the level of the country. Okay, so, worldwide maternal mortality has been declining. And still in certain countries, it's still quite high. Although it has been progressing as incomes increase, as access to healthcare increase, we've seen a sharp decline in maternal mortality across a number of nations. As far as Ethiopia is concerned, maternal mortality reduced dramatically, depending on the source that you use, whether you use the WHO source or you use the University of Seattle data source. It has reduced mortality by about 70% between 1990 and 2015. So that's really dramatic. And what we wanted to check in this paper was what is the role played by these two programs, what's called the Health Extension Program and the Health Development Army, in trying to reduce this mortality. So our aim is, look, mortality has declined. That we seem to know from all sources that seems to be the case. Yet it's higher than the world average. But what has been the role of these programs? And these programs are what's called the Health Extension Army. And the Health Extension Army was about posting 2 healthcare workers in health extension posts in every single village of this country. The focus of this health extension program was on preventive healthcare measures. And what was noticed in the country was that, look, this program was great, but it needed a boost. It needed a booster shot. And then in 2011, this so-called Health Development Army was introduced. And I'll talk about that a bit more. But the health extension program is not so unique to Ethiopia. You see that in lots of different countries. What you see here in the picture is one of the co-authors, GetNet, who's sitting with a health extension program worker. And so this is the kind of small clinic type of setup that you have. It's a small health post, actually, it's called. And you see all sorts of charts in the background and so on. So that's the health extension program, preventive measures, access to knowledge, small amount of preventive and a small amount of curative medicine is available. Mainly it's about family planning and the health extension programs and sanitation and so on. So in 2011, the Health Development Army was introduced. And as I said, that it's got this sort of exciting name, Health Development Army. And the idea was to place the desire to reduce maternal mortality on a war footing, on an army level footing. And so that's sort of telling you what the Health Development Army is about. So it's a government-supported program. It's a women-centered community movement. And what happens is that you first go to the health extension program, get training out there, and then you have a bunch of households called the model households. These model households are those who understand how to implement all the elements, or the 16 elements or so of the health extension program. And then they become model households, and then they work to set up this Health Development Army. It's a group of 1 to 5, it's called. So you have a leader, and there are 5 women along with this leader. And these 1 to 5 networks go around talking about healthcare issues, mainly to do with maternal mortality, use of antenatal care, getting women to hospital, getting women to give birth through skilled birth attendants, and so on and so forth. So that's the way they work. They set up these small networks and of pregnant women, essentially, and then they work with them before childbirth, during and after childbirth, to try and get them access to healthcare, to provide information on best practices, where to go, and so on. So we have in the paper a bit more detail on how this functions. This has been criticized for lots of reasons, and perhaps you will raise that in the discussion. And it's quite invasive, you might say. But in any case, our program was not to get into the politics of this of this construction, but to take a look at whether this works. So by 2013, a large number of the health development teams had been set up, and it covered about 13 million households. So you can talk essentially if the country has about, let's say, a population of 110 million, average family size of 5 or 6, you're talking about 20 million households. So a large proportion of the households of the country had been covered. And on the face of it, they seem to be delivering remarkable results. And that's what we want to check, whether this is true or not. In terms of maternal mortality, that's what the paper is about. But also in terms of antenatal care, we saw phenomenal results. Access to antenatal care increased from 34% to 62%. Proportion of deliveries taking place by, in the presence of skilled birth attendants also rose. So that's sort of the background and context of the paper. And so the HDA works very extensively with these health posts and the health extension workers to promote access to modern healthcare. And as I mentioned, the focus is very much on the use of ANC and the use of skilled birth attendants. And you can see a couple of pictures here. Here we are, the first picture, we are sitting in the office of the medical, the person who runs the district medical care, collecting data, getting information. On the right-hand side, you see that this is a chart, very much like the participatory development approach that some of you might be aware of. These are different houses, and you have, we saw this on the wall of somebody who runs the health development army. So they identify pregnant women, and they identify how to work with them and interact with them and who will talk to them and so on. So that's sort of grounded community setup that we have. So what do we find? Well, before we get to what we find, just to give you a sense of what's happening, this is sort of a picture which shows you the decline in maternal mortality. You see starting at the beginning out here about 800, 850 in 1990, and in 2011, maternal mortality, which is the number of maternal deaths per 100,000 live births, drops to around, here you see about in 2011, when the HDA started, about 450, 500. And we are analyzing essentially what happens between the period once the health extension program starts onwards. So the before period is 1990 to 2003, and afterwards is 2003 to 2016. So we have a nice before-after period. But how do you compare Ethiopia with? How do we, we want to control. So what we do is we form a synthetic Ethiopia. We take a pool of 42 sub-Saharan African countries that have not implemented such a program and use information about these countries to create an artificial or a synthetic Ethiopia. So what is going on is we take these 42 African countries, we find a combination of these countries which is as close as possible to the outcomes in Ethiopia before the program started. And we create an artificial Ethiopia. So we give more weight to those countries that are similar to Ethiopia and less weight to those countries that are not similar to Ethiopia. And we create this artificial Ethiopia. So we compare the actual numbers in Ethiopia with this artificial synthetic Ethiopia. And this kind of technique has been used to analyze macro level programs in lots of different settings. So you don't compare Ethiopia with another similar country, but you compare Ethiopia with an artificial combination, a weighted combination of 42 different countries, and to get them as similar as possible to what Ethiopia looked like before the program started. Okay, so, and I can answer some more questions later on if there are questions about how do we go about creating this. So I'll show you another picture. So 1999 to 2003, the baseline period, and you see these two lines out here. A blue line is the actual situation in Ethiopia, and the red line is what we observe with a synthetic Ethiopia. And the idea is to match in the baseline the synthetic Ethiopia with the actual Ethiopia as close as possible. And so that's what we do here. You can see that it's quite close in terms of the key outcome, maternal mortality during the baseline period. So our argument out there is that during the baseline period, we have a good match, that we've been able to get a synthetic Ethiopia which captures what would have happened in Ethiopia if Ethiopia had not implemented the health extension program and the health development army program. That's before the program. And then 2003 onwards, we have after the program. And so the gap that you see between the red line and the blue line is what we claim is the impact of the program. So keep in mind, we're not saying that the entire change in maternal mortality is because of these programs. We're trying to isolate how much of this change, which is quite dramatic, how much of this 70% decline can be attributed to these interventions. So you have a counterfactual, that's a synthetic Ethiopia, and you then have the actual Ethiopia out there. Okay, and so we're trying to figure out the extent of the change that we can attribute to this to these interventions. Okay, so what do we find? You find a list of numbers out here, but these are essentially the maternal deaths averted you see out here. What you see -15, -23, -32 is the gap between the synthetic Ethiopia and the actual Ethiopia. And so this is the number of reduction in maternal mortality per 100K live births. So what we claim is that between 2000 and by 2016, the gap between the synthetic Ethiopia and the artificial Ethiopia was about 176 maternal deaths, less maternal deaths per 100,000 live births. And that's essentially what you see in the picture. This gap, this impact, this comes from our empirical work, is the impact. And this gap is about 176 deaths per 176 maternal deaths less per 100,000 live births. Okay. And that's what we claim is the impact of the program. Now, we don't have p-values here and all the statistical stuff, but that's in the last 4 or 5 years, we can show that these are statistically significant numbers. This sharp decline after 2012, 2013 is indeed because of the program. So these are the main findings, essentially, that between 2003 and 2015, Ethiopia's maternal mortality declined by about 70%. What we claim is that about 37% of this decline, not the entire decline, but 40% of the decline actually in the paper we write, is because of these two programs. The rest is because of increases in GDP and increases in access to healthcare and also other things. But explicitly due to these programs, we claim that about 37% of the decline is due to these programs. So it's a very low cost strategy. These are volunteers who are part of the Health Development Army. And so we argue that, look, this kind of access to community healthcare or this kind of community intervention has led to a sharp decline. It's clearly an example worth emulating. Whether this can be done and transplanted to other countries, of course, is not so clear because these programs in Ethiopia have a certain history. There are certain circumstances in the country which allow such programs to be implemented at sort of with using volunteers. But indeed, it's an example perhaps of going with the theme of the conference, what a country in Ethiopia, what a country in Africa has been able to do to reduce maternal mortality in a short span of time at a very low cost. And I'll stop at that. Thanks, Zemzem.
Thank you, Arjun. You finished really on time. If there are any pressing questions that wouldn't wait till the end of the presentation, now is the time to ask, Arjun. Oh, Ton, please go ahead.
2 quick questions. Of course, your data are up to 2015-16. Any idea what happened afterwards? And then the second question is, to me, this sounds like that Ethiopia has taken examples from India, Bangladesh in the way of doing things. Where did they get this idea to do it this way and to use this approach?
Okay, Tom, thanks. I have, as I said, Anagha, my co-author, is there, so perhaps he can also jump in to explain some of these things. I think that what's happened after 2016, we have to go and check. In fact, we have another data collection exercise that we just completed, which Anagha just completed from hospitals and clinics to take a look at what has happened, actually more to do during the COVID times, not so much after 2016, because we were very concerned that with sort of reduction in access to healthcare, perhaps with sort of less use of ANC, less use of postnatal healthcare, there might be an effect on maternal mortality and on healthcare outcomes for children. So we've just got the information. We're going to analyze that fairly soon, but we don't know as of now. In fact, there are concerns that things may have changed since then. So that sort of still has to be investigated. We don't know yet. And indeed, our data lasts till 2015, 2016. Also, I have to tell you that the data, it's sort of maternal mortality data is very difficult to believe sometimes. Okay, after using it, we can say that. That's a point that we do plan to follow it up now, especially in the short span of time to take a look at what's happened in terms of access to healthcare. Initial analysis of the data shows that actually after a little dip in the early months following the imposition of various lockdown measures, there hasn't been a very large change in access to healthcare. But Anago, are you there? Anago? Well,
yes, yeah. Arjun, I'm there. Yes, yes.
Yeah. So, isn't it true that there does not seem to be been a very rapid change or very sharp decline in access to healthcare during this time period?
There is no decline, but also the same thing. There is no any increase or decrease.
Yeah. So it's like. So yeah. It seems relatively stable in a sense.
Yeah. Definitely.
Yeah. I think, Ton, in response to your first second question about indeed this idea of barefoot doctors and access to healthcare and through sort of there's a history in China of such workers, the history in Bangladesh, history in India of such workers. So I don't think the idea of having community-driven initiatives is new. I think what is new is the way it's being executed in Ethiopia. These ladies are evaluated. There's a whole evaluation system. They get ranks A, B, C. They are very well connected to the health extension program. So I think it's the sort of the sense of urgency with which it was being done, which I think is quite different. And perhaps the inspiration did come from these earlier initiatives. But I think the idea of forming these community groups is an Ethiopian idea, this sort of 1 to 5 network. They implemented this for other development outcomes as well. And maybe Desayen or Anago have some views on that. But I think that this construction is relatively unique. The basic idea of community-driven initiative is not new, but the way they're executing it, the extent, at least in the early time period, the way they went about it, I think is relatively unique. The rhetoric, right? This notion of a army, I mean, that's not coming from China or maybe from China, but not from India, not from Bangladesh. I think this rhetoric is not from either of these places. But Desayen, Mesret, Anago, you are stalwarts in the healthcare programs in Ethiopia. So maybe you want to join in to comment on that. Anago?
Yes, I don't know exactly how initially the idea came, but what I can tell you is that most of health problems in Ethiopia are like communicable diseases, and the way they can be prevented is not that much costly. So the government wants to design appropriate strategy at the ground level, which can cover majority of the people, especially in rural part of the country. So first they train what we call health extension workers, so that they can disseminate health information, especially related to personal hygiene and also maternal child healthcare services issues. Plus also they involve the community at large at the ground level, so that they can take care of their health and the environment. So the idea is that this was a majority of the health problems, more than 70%, used to be due to communicable disease. That's how the program was designed initially.
Ton, is your question answered?
Sure.
Okay.
Very interesting. Yeah.
Thank you very much, Ton, for the question, and thank you, Arjun, and also Anagao, for providing the explanations on the questions from Ton. Now, I would have liked if we stayed in Ethiopia and I presented the findings from the research that we did. But Akoko would like to go second and to say a little bit about Akoko. Akoko is a PhD student in the Department of Anthropology and Sociology at Alassane University in Bauchi. She is also a fellow of Africa One Health associate researcher and a member of the research group Governance, Society and Development Economics, which is GESD at the Center for the Scientific Research in Cote d'Ivoire. Her current work on under the One Health in Africa program focused on the social life of knowledge produced in zones in Africa. and she has done this work together with Catherine Head-Stokpa, and she's her student. Coco will present today the politics of knowledge production and transfer in the field of One Health in Africa. Coco, the floor is yours.
Thank you. I'm happy this morning to be with you on this platform. We share our results produced on the policy of the knowledge produced and the transfer on One Health, in the field of One Health in Africa. So give me some minutes to share my screen. The work was done on this topic, the policy of knowledge production and transfer in the field of One Health in Africa. As an introduction, zoonotic disease. Zoonotic disease are a group of infectious diseases that are naturally transmitted from animals to humans and vice versa. The well-known zoonotics are SARS-CoV-2, as what we are experiencing now, COVID-19, Ebola, rabies, and so on. In the world, zoonosis disease had been caused, actually 2.5 million of human cases, illness, and 2.7 million human death. And also, as an example now, COVID has been one of the zoonosis that is in the realities. And we can record, we can show that over 2 billion of women deaths now in the world. And to control and prevent zoonotic disease, One Health approach is required. One Health approach, what is One Health approach? One Health approach is the added value of a close cooperative between human and animal health and related disciplines and sectors. Again, to see as this picture is showing, the added value now is given from the One Health approach is the better health outcome and also the financial saving. We have seen that many work have been done in the field of One Health, but this study focuses on the Africa-based research network, Africa1. This program works on 5 thematic training programs, which is called TTPs on zoonotic disease. And we focuses on 3 major TTP for our study. The TTP1, the TTP2, and 3. This is all about the background of the study. Our general objective is to explore how the present body of knowledge on zoonotics has been shaped by structural aspects on how research is done. And for that, we have 2 specific objectives. The first one is to understand how team emerge and got financed. And the second one is to investigate how research results were disseminated for use to improve health outcome in Africa. What did we find from this study? From the first objective, the study showed that the research topic emerged from so many aspects. One, from outbreak or the severity of the disease. And we can record from one of our response from the TTP brucellosis, who says, I cite, we shifted to rabies because there were a good number of cases of people bitten by rabid dogs. People are suffering from rabies, dying from rabies in Tanzania. Again, the zoonotic disease topic will emerge also from the country priorities. And we can see again from the quote from the TTP tuberculosis. They have just established the natural tuberculosis control program in Ghana. And in my country, TB is a priority. And again, we can see that knowledge that was produced on zoonosis and taking One Health approach has been emerged through a notification of social problem. Also, it has been generated from other project work and the surprises endorsed from the field. And now from this result, we mostly see that the work has been driven by the sectors of human and veterinary medicine. What can we find from the second side of the funding? Regarding the funding, zoonotic projects primarily financed by international funders. And we can see again from this quote that we receive from our response. The one of the TTP brucellosis, he said 100% of funds are external. We can see again that from the TTP rabies that sociological, epidemiological, veterinary, medical and economic research also were financed by the same funders as international funders. Back to the second objective, we noticed that they study the program of Africa One Aspire use so many channels to disseminate their results. Either presentation and the publication in open access, the report, they use also social media to share their knowledge, the press, the policy brief for the useful of the knowledge produced. And it can be seen also as from the quotes from our respondents. Let me take the one from the rabies. One of the rabies, TTP rabies, I cite. You will see all access on internet. That shows that all the presentation, all the work have been done, not only be present, but it have been published also on internet, and which is accessible to everybody. The other hand of how research uptake and the social impact of the work produced under the program Africa One Aspire. We notice again that most of the study have had a social impact. And this, we can thank our stakeholders' engagement in that work. And we can share that from the work done by TTP, COOP, it led to the establishment of nationwide quality assurance system in tuberculosis laboratory in Ghana. Not only is the public sector, but private sector also involved in that fight. Again, the work done under TTP rabies showed that the results allow Côte d'Ivoire, for example, to redesign its strategy for rabies control. This is translated to a national rabies control program. From the TTP brucellosis, we can record that the data will be used to develop national intervention strategies in Senegal. The 3 TTP that we were focusing on, they were in different countries together as a network under Africa One Aspire. And our result from the first objective was also corroborate with the work done by Hornboard, Dashon, and Todd, who found that the majority of the work on One Health across the world is constructed around medical teams. The work also of Labor and Toll, Can and Toll also have been confirmed that environmental and ecological sector have been neglected within One Health research. And the research evidence used in the policy and practice decision due to the strong stakeholder engagement. This aspect is very crucial for the program. And here is the summary of our results. I would like to acknowledge all these institutions and partners. Back to you. Thank you.
Thank you very much, Coco. And you also finished on time. That is very interesting. And I would like to say that now the floor is open. If there are any questions to Coco, which cannot wait till the end of the presentations. I don't see any questions coming to you. Maybe questions will come up at the end of the presentation. Now I will start my presentation. To introduce myself, my name is Zamzam Chukute, and I'm based at the International Institute of Social Studies. And I am assistant professor in global health and development. And today I will present a joint work that we did on the effect of the Ethiopian community-based health insurance on resource mobilization and quality in healthcare. Let me share. Can you see my screen?
Yes, we can.
Yes, we can see.
Okay. Wait. I should be sharing the PowerPoint presentation. Okay. All right. This is a joint, as I said, this is a joint work with two of the co-authors are here, Arjun and Nagao. And In this paper, we explore the effect of the community-based health insurance on resource mobilization and quality in healthcare. But before I go to what we did and what were our findings from the study, I would like to give you a little bit of the background information and what gave us the motivation to do this research. The Ethiopian government, with objective of expanding primary healthcare, strengthening the healthcare system, and enhancing the health targets that align with the now Sustainable Development Goals, but before the Millennium Development Goals in the past. The government has been plugging substantial supply-side investment in the healthcare infrastructure, and you also can relate this to the Health Extension Program and Health Development Army, which were implemented in line with this strengthening the healthcare infrastructure. But despite this huge investment in the healthcare sector, the healthcare utilization was there was not much change in healthcare utilization, and the Ethiopian government looked at this bottleneck and tried to come up with initiatives that can help in enhancing healthcare utilization. And one of these interventions that the government came up with is the community-based health insurance. And this community-based health insurance scheme is objectives the increase in demand for healthcare services and enhancing the financial protection by reducing the burden on out-of-pocket expenditure, and it also tries to generate revenues from domestic sources for the health sector. Well, to say a little bit more on this community-based health insurance scheme, it is a scheme that was initially piloted in certain districts found in 4 main regions of the country. And initially, when the piloting was done, there were only certain districts, but now this has reached to close to 637 districts. And looking at the number of beneficiaries or the number of people that are enrolled in this scheme, we have around 23, almost 24 million beneficiaries looking at the data of enrollment in 2019. And the main objective, as I said, it tries to increase demand for healthcare services and also enhance the financial protection of those covered by the scheme, and use it as a mechanism to generate resources for the health sector. And this is something that comes together with the healthcare financing reform the country is implementing since 2014. And this healthcare financing system is something that allows the fee retention by healthcare providers, and they use these generated resources in order to improve quality in the care they provide. And looking at community-based health insurance schemes, mostly in low and middle-income countries, these community-based health insurance schemes are usually voluntary, and these voluntary schemes, although they were successful in enhancing the financial protection for those that are covered by the scheme, and also enhancing access to healthcare, they struggle a lot when it comes to expanding the enrollment and also retaining those that are enrolled in the schemes. And to mention some works in relation to this, in relation to identifying these bottlenecks of community-based health insurance schemes, we find Nabrate and Diaz, other colleagues, who did a systematic review on 46 community-based health insurance schemes, and their finding showed that the average insurance scheme uptake was around 37%, and they also found out that there is high dropout rates in these schemes studied. And other work by Krell and Wilkins looked at a scheme in Guinea-Conakry, and the report that came out from this study was there was a dropout rate of around 25%. And again, another study by Dong and colleagues showed that there is dropout rates that range between 31 and 46%. And this again, another study by Ladowski showed a high dropout rate ranging between 58 and 83% for 3 schemes that were implemented between 1997 and 2001. One important factor that comes out from all these studies and also other studies that looked at community-based health insurance schemes is that the quality, whether it is perceived or quality captured by different indicators, appear to be a prominent reason that is obstacling the continuation of enrollment and expansion, as well as expansion. And coming to what motivated this research, the research is motivated by one, the limited literature, or which look at the effect of community-based health insurance on revenue generation and quality of care. And second, we believe that the potential interplay between quality of care and CBHI uptake and retention has implication for community-based health insurance schemes sustainability. So with this, the 3 research objectives that we look at are, first, we try to examine whether there is a resource coming to the health centers that were affiliated to community-based health insurance. And we look at whether this the effect of the community-based health insurance on resource mobilization it goes further to affecting or impacting quality of the healthcare provided, and we look at perception measures as well as indicators using different quality indicators. And we also look at whether there is an effect on the perception of the healthcare that was received by patients. To make a little bit of the picture more clear, we also look at and ground ourselves in conceptualizing the quality in healthcare. What do we mean when we say quality in healthcare? This is a concept which is very much complex as it captures subjective and objective indicators. Some might be very clear and straightforward, while the others are a little bit complex. And looking at the definition that is provided by the World Health Organization, which captures different definitions and different indicators, The World Health Organization defines quality in healthcare as the extent to which healthcare services provided to individuals and patient populations improve desired health outcomes. Well, this definition, although it looks very much straightforward, it gets complex when it goes to really measuring the quality in healthcare. And going back to the different works that were that tried to look at the quality in healthcare and conceptualizing it, we find Donabedian's work, which started in 1996, and he proposes quality in healthcare to be defined as a framework of structure, process, and outcome that mainly that try to capture the various dimensions of healthcare inequality. And when we say structure, there are indicators that fall under structure. For example, the availability of equipment. It could also be the availability of human resources, quality of human resources. And coming to process relates to the process or the how tests are handled, how the services are provided. And coming to outcomes, it relates to outcomes on health relating to mortality, morbidity, and also satisfaction of the care by the patients. Looking at the studies which have tried to look at the effect of CBHI on revenue generation and quality of care, this is an area where we really don't find many studies that have been done on it, but looking at the few gives us a kind of mixed evidence. Looking at, for example, if we look at the systematic review that was carried out by Ekman, he concludes that the CBHI schemes have moderate effect coming to cost relating to cost recovery ratio, and these studies also didn't really show evidence when it comes to the effect on quality of care. Another relatively recent and also large study by Span and his colleagues found a strong positive effect on resource mobilization, but the effect on whether it is structural and perceived quality of care was really weak in this that was shown in by the systematic study. And the one conclusion that came up from this study by Span and his colleagues is that CBHI schemes can be used as an alternative to user fees, and they can also be can be used as a promising means to achieve universal health coverage. Well, with the objective that we had, we were lucky that we had two sources of data, and the first is health facility survey data, which comes in 2 rounds, and this facility survey encompasses 48 health centers that were located in 12 CBHI pilot districts, and 12 out of the 13 initial pilots, and 4 control districts. And we surveyed 3 districts from each of the districts. That brings the 48 health centers. And the information that was collected expands from the monthly data on outpatient and inpatient visits, information on the availability of essential drugs, availability of equipment, and we also look at whether the health centers that were surveyed had weaknesses or blockades in delivering quality service. And we also did exit interviews with 5 patients per facility. And then we also spoke to the patients as well as the heads of the health centers. And other data that we used for this study comes from 3 rounds of household data. And the household data was collected in 2011, 2012, and 2013. And also there are many things that were covered by this panel data. We focus for this specific study, we focus on the data on individual and household socioeconomic characteristics, demographic traits, health status, and healthcare utilization. And the main indicator for that is used in our analysis is patient satisfaction with the healthcare received. And this was measured in a Likert scale, and we have 1,156 individuals over the 3 years. And to connect it to the health facility data, we used geographical mapping based on the location of the individuals. We have, for the 2 data sets that we used, we have corresponding frameworks. The first framework corresponds to the health facility based outcomes, and here we do difference estimation of our outcome of interest, and this is regressed on several factors. And the main outcome of the main indicator of interest is the CVHI. The CVHI interacted with the time, and we also control for other time varying controls and the time trend, as well as a fixed effect for the health facilities. For the second framework, which corresponds to the household survey outcomes, we look at the patient satisfaction as a function of the CVHI interacted with time, as well as observed time varying covariates and time fixed effects. Coming to the results, we see that the results that is shown, that comes from the health center contract signing status, we see that there seems to be a positive effect of signing signing a community-based health insurance on indicators of the resource mobilization, as well as some indicators of quality. And this is from the first picture that comes out from the descriptive statistics. We didn't stop at this, and we tried to look at using the difference in difference estimation. And as you can see here, there is an effect of the CVHI affiliation for the health centers in terms of the increase in monthly volume of outpatients, and we also see a positive effect of the scheme on revenue from patient card, the revenue from drug sales, and overall revenue that also includes revenue from the source of giving service to CVHI affiliated or CVHI enrolled patients. And we didn't stop at this. We tried to look at how money that is generated is used by the health facilities. And we see that in responding to the questions how health facilities spend the money, we see that the most reasons that that were identified by these health facilities are they use them to purchase drugs, disposable equipment, and durable medical equipment. And look, based on these responses, we try to look at whether it is whether we find this in terms of the drug availability, medical equipment, and other indicators of structural indicators of quality in healthcare. We didn't find a significant effect of the scheme on these indicators of structural quality in healthcare. But when looking at whether the CBH affiliation has an effect on the perceived quality in healthcare, which has mainly to do with solving the bottlenecks for the health facilities, we see that there is those affiliated health centers reported reduction in terms of the reporting problems of drug shortage as well as problems of budget shortage. And coming to the satisfaction indicator or the analysis on the individuals, we see that there is an indicator of satisfaction from the treatment that patients receive from contracted facilities compared to healthcare provided by non-contracted health centers. And when we went to the analysis using the regressions, we also find this positive effect of the CBHI affiliation on patient satisfaction. And coming to bringing all the analysis together, we see that there is a sharp increase in the number of outpatients. These outpatient visits to CBHI affiliated health centers, and this is not only particular to this study, but earlier studies on the scheme have also showed this significant increase in number of outpatients. This is not surprising, but when we also look at whether this increase has an effect in resource mobilization, we see that there is an increase in health center revenues. And it looks like the health centers are using these increased revenues in improving the quality in the care provided. And this also relates to the virtuous cycle of quality and resource mobilization. And on the other hand, from the analysis using the household survey, we see that those patients that received healthcare from CBH affiliated health centers showed an 11 percentage points increase in the satisfaction. And this is quite significant. And bringing all the findings together, what we can say about the Ethiopian health insurance scheme is that it is it appears that it is able to negotiate the major stumbling block of enhancing enrollment as well as improving retention in schemes, which I discussed in the beginning, where I said for schemes mainly in sub-Saharan Africa, the major stumbling block has been poor quality of care, but it does seem that the Ethiopian the Ethiopian community-based health insurance is able to come over this, to overcome this obstacle. And the other story that we can bring from our findings, as well as the works by the previous works on CVH, as well as other schemes like the Health Development Army and the Health Extension Program, is that the combination of supply side investments seem to work positively for the community-based health insurance. And what we can say from the results of this paper, as well as the results from other studies on the Ethiopian health insurance scheme, the scheme seems to align Ethiopia with Rwanda and Ghana in enhancing access to healthcare and working towards universal health coverage. Thank you very much. Now I have finished my presentation. If there is any question for me or anyone in the panel, now is the time.
I think Ton had some questions in the chat box. I don't know, Ton, whether you want to read them out or.
Sure, but maybe there are others as well. I don't want to dominate the. But if there's other people still thinking about a question, indeed, let me go back to the second paper of Akoko, and what it seems a lot is happening there in this field of connecting the health sciences on the one hand and veterinary sciences on the other hand, and a lot of that connection is also very much funded by sources from outside. But I wonder what is happening within African universities. Do you see that the health sciences taught there and the veterinary sciences taught there come together in one way or another, and that students exchange and that staff exchange, that they work together? Or is this still a very separate field?
Okay, thank you, Tonte. Actually, before they were working separately. Yeah, at the university level, we found that the veterinary work, for example, on brucellosis, and social scientists, for example, who look at the behavior of people, of the transhumant, the people that raise animals and so on. So they work now together, even at the university. Though they are students, but they are working on the same, let me just say, in the same topic, but different way, but together on that same disease.
Okay.
I can just say, add that in Africa One Aspire is a program that have a network from different countries, and all the students are working under that 5 TTPs. And one TTP now, a veterinary can work, and a human health person also can work, and together they will share the knowledge about how to implement the result, how to communicate, and for the policy engagement, and a lot of study have done on that way.
Okay, that's very encouraging. And I suppose there are many more faculties of medicine than there are faculties of veterinary studies. So I assume in every country there are only 1 or 2 universities with veterinary studies. So how do they connect to the multitude of medical faculties?
Oh, okay. For that, it's a process. Now, this one for their joint work is ongoing. It's not well settled, but through the platform one have, and everybody has been having the knowledge of how to work jointly, even at the university level.
Yeah, thank you.
I see a question for the paper that I presented from you, Tom.
Yeah, sure. The results are really encouraging, and also the massive scale that you see in Ethiopia is like with the paper of Arjun. It's really impressive. This country is going very rapidly, at least was going very rapidly in a direction of really rapid changes and improvements. Now, elsewhere in the Africa Knows program, we had a number of presentations about other types of insurance. For instance, the agricultural insurance or ways to cope with climate change related insurance. Now, maybe you know, but is there a tendency that people who now accept these community-based health insurance systems, that they are also accepting other types of insurance? And if so, what findings do you have there?
Okay, thank you very much, Ton. Arjun and Nagao can also help me in responding to this question. But so far, from what we know, there is an insurance in Ethiopia, especially on, they call it weather insurance, and they try to, this is designed for the households, and it is an insurance for weather related shocks. And it appears that the system of what Arjun presented as the Health Development Army, it is also there for agriculture. For instance, there is this agricultural development army, and they generally call it development army. And those systems of this development army, health development army, women development army, seem to work in bringing people to be insured, whether in the community-based health insurance or other insurance schemes. And what is on the ground is really working in terms of enhancing different types of insurances.
I mean, just to
Thank
add
you.
to that, Don, I think it's a very interesting question you asked, but the facts are that we've not looked, we at least in our work, have looked at the synergies between CBHI, the health insurance, and the productive safety net program. We've looked at synergies between those two, but we have not looked at the synergies between having access to one insurance and understanding what insurance can do and other insurances. The work that I know by IFAD and others, either Alexander Saris and people like that, they look strictly at weather insurance, so they don't look at health insurance. And we look at health insurance and don't look at other insurance. So indeed, we recognize the synergies between the two, and that's why we have a paper where we look at how the PSNP, which is the big social protection program in Ethiopia, sort of interacts with the CBHI. But I think that's an interesting construction to look at. In fact, we've done the opposite. What we are trying to look at now is, if you have access to CBHI, do you stop contributing to informal insurance? So we've gone the other direction as compared to what you're suggesting. You're talking about crowding in. We are talking about crowding out. And we have we thought, we haven't yet executed it, but our concern was that once you have access to formal insurance, then what about informal insurance? Do you stop contributing to remittances for families? Do you stop helping others and so on? And that was, in fact, our concern. But both ways, I think it's an interesting issue to look at.
Yeah, thank you.
No, not to add. I think you both addressed very well. One thing that I would like to say here is that in Ethiopia, we don't have different types of insurance programs. We have health insurance and agricultural insurance, or weather insurance specifically. But this is not available everywhere. It's only in some selected waradas or districts of the country. So like what Arjun already stated, it's good to see if there is like crowd out or crowding between the two insurance programs. Otherwise, we don't have it so far alternative kinds of health insurance program. I have one question for the second presentation. That's about the commitment of government, especially Ministry of Health in Africa, about to encourage or promote generation of knowledge and then their interest to use for policy purpose and so on. If I see in my country now, most of government officials at Ministry of Health, Ethiopian Health Insurance Agency, they are really interested to see evidences from universities and other research institutions. But what I see a gap in my country is that they don't really push it from the ground. That means they don't allocate budgets on yearly basis, and they don't also contact universities unless the universities ask the ministries for a presentation or to disseminate knowledge. They don't really push these kinds of activities. So I wonder what's your view about other African countries? Thank you.
Thank you, Anagwai, for your question. In let me say in West African, it's not far from your side, because even at the Ministry of Health and Ministry of Human and Animal Resources, they have some researchers there, and their work they have been doing is just stay from their side. They not even go further to the university to do more of that. There are few researchers in that ministries, but I just want to say is the program. Let me see, the program Afrikwanda is trying to actually make that way to be work in universities in, let me say, in West Africa. So it's not really different from your side, it's the same, but now we are doing a process on working on that so that it will not remain the same. Thank you.
Nagao, are you done with your question?
Yeah, thank you.
Okay. Okay, then if there are no other questions, I would like to thank everyone for participating in this panel and say bye-bye. See you later. Thank you very much.
Okay, bye. Thanks, Zamzam.
Bye.
Thanks, everyone.
Thank you.
Bye. Bye. Thank you, Zamzam.